Okay, we're going to get started. So today we are talking about hypothesis generation. I'd like to first off apologize for getting the slides posted so late. I had a computer accident while I was in Malta, and then I got stuck in Chicago, so I didn't get back until about midday yesterday. So that's why the slides were posted so late. So hypothesis generation, right? Basically, how do we come up with ideas in epidemiology? So the purpose of descriptive epidemiologic studies is often for hypothesis generation. That's not the only purpose, but that is one of the main purposes, whereas analytic epidemiologic studies are usually for hypothesis testing. However, sometimes in analytic epidemiologic studies, we also end up doing hypothesis generation, and I'll talk a little bit about that towards the end of the lecture. Okay, so this is some quotes from Wade Hampton Frost, right? Epidemiology at any given time is something more than the total of the established facts. It includes their orderly arrangement into chains of inference which extend more or less beyond the bounds of direct observation. Such of these chains as are well and truly laid guide investigation of the facts of the future. Okay? So he goes on to say basically that a nearly perfect model of this is John Snow's analysis of the epidemiology of cholera. Do you guys all know that story? Yes, you've heard that story. Okay. So which led him to the confident conclusion that a specific cause of disease was a parasitic microorganism, confirming in all the essentials of its natural history to what is now known as cholera, right? Vibrio cholerae. Okay, so in epidemiology, we'll have, you guys haven't had the causal lecture yet, okay? We're going to talk about that later in the course. But basically, what we're concerned with, our main thing that we would like to do, the holy grail of epidemiology, is to prove causation, that some exposure leads to or prevents disease, right? So an epidemiologic hypothesis generally takes on the form, we say exposure to X is associated with an increased or decreased risk of outcome Y, all right? So an example of that would be cigarette smoking is associated with an increased risk of lung cancer, all right? Or wearing a helmet, so exposure to a helmet, is associated with a decreased risk of dying from head trauma in a motorcycle accident. So if the hypothesis that you postulate is correct, the risk or the rate of the outcome in question, whether it's increased or a decreased risk, among those with the exposure will be higher among those with the exposure than it is among those without the exposure. So the idea is cigarette smokers will experience, if your hypothesis is correct, cigarette smokers will experience an increased risk of lung cancer compared with non-smokers, okay? And so the same thing with motorcycle helmets. So motorcycle riders who wear helmets will have a lower risk of dying from head trauma compared with motorcycle riders who do not wear helmets. So basically, we make a hypothesis, and then we test the hypothesis, design a study to see if our hypothesis holds up. Okay, so there are a lot of different sources of epidemiologic hypotheses. You can have individual cases leading to a hypothesis, case series, descriptive epidemiologic findings, and that includes ecologic and migrant studies. Okay. Data dredging. Do you guys know what data dredging is? Basically taking a database and just looking at all the different things that you could possibly look at and see if there are any associations that you find. Laboratory or animal studies. Analogies to other exposure outcome relationships. Common sense. Okay. Sometimes it's luck or chance that leads you to a hypothesis. And then there's also other epidemiologists or publications. Okay, so how to find a hypothesis to test, right? I would say the main way nowadays to find a hypothesis to test is to read the scientific literature, okay? And to do that, you guys are all familiar with PubMed? Yep, more or less, right? So you do a PubMed or another database search, pull all the literature, compile it, maybe write a systematic review or meta-analysis to look at the current state of knowledge and where we're really lacking in knowledge. You can also examine descriptive epidemiologic data, Listen to patients or their families if you're a clinician. Listen to clinicians if you're not a clinician. Read the newspaper or watch television. All right. So we're going to go through different examples of how basically here, right, these different sources of epidemiologic hypotheses, give you some examples. Now, I am not saying that these hypotheses are correct, all right? I just want to bring up some examples of how different, how individual cases have led to a hypothesis, case series, etc. All right, so one example is the use of cellular phones and brain tumors. Okay, that was an individual case which led to a hypothesis. Another example is working in the electronics industry and cancer. So in 1993, a guy named David Raynard, who lived in Florida, filed a lawsuit claiming that his wife's cell phone had caused her brain cancer. Okay, so what he basically said was, well, the cancer was on the same side of the head that she normally talked on the phone. She talked on the phone a lot. And the cancer looked roughly, like it was roughly the same shape as the antenna of her cell phone, right? So he went on the Larry King Live show and said, cell phones cause cancer. My wife died of cancer that was caused by her cell phone. Became highly publicized and people became very interested in, do cell phones cause cancer? What do you guys think? Cell phones cancer? No. Yeah, I don't actually believe it either. There's very, very little evidence. There are a lot of studies that have been done. Okay, almost all of the studies have shown absolutely no association. However, the WHO recently released or announced that cell phones may be carcinogenic based off of a big, I think it was 10-country study that was done in Europe. So I guess the jury's still out, although I don't personally believe it. There's no, the problem with the cell phone and cancer thing is there's no real biologic plausibility. There's no reason that we know of, at least, that they would cause cancer. Okay. Case series leading to a hypothesis. So you have ionizing radiation and selected cancers. All right, cigarette smoking and lung cancer. DTP, right, so your diphtheria, tetanus, and pertussis vaccination, and SIDS, sudden infant death syndrome, or neurologic damage, silicone breast implants and connective tissue disease, swine flu vaccine, this is the one in the 70s, okay, and Guillain-Barré syndrome. All right, so ionizing radiation and cancer. We now know that ionizing radiation does cause cancer, right? Especially in large doses. But back in the early 1900s, we didn't know that. And so there's a very famous thesis. This was actually somebody's PhD dissertation, where she took a collection of 104 cases of cancer. These were in people that had high exposures to ionizing radiation, so radiologists and the like, and kind of put it together and said, look, it looks like this could cause cancer. So her name was, and I won't say it right, Sophie Fajan? I don't know how you would pronounce that. Okay. So smoking and cancer, same thing, right? Basically, they saw this huge increase in the number of lung cancer cases, and they did a case series, wrote up a case series about it, and said, we think that this increase may be in part due to increases in pollution and other things, but really what we've noticed is all of these cases are smokers. So we think that smoking is leading to an increase in lung cancer. DTP and SIDS. Okay, this was basically, they noticed from data that it looked like a lot of SIDS cases occurred very close to vaccination. All right, and so it led them to hypothesize that vaccination with DTP led to an increase in sudden infant death syndrome. You guys see any problems with that particular hypothesis? Any thoughts about that? Yeah, so that's exactly right. They would happen around the same time frame. So if you look at a bunch of SIDS cases, you would expect that some of them would happen very close to vaccination, right? Because their infants get vaccinated and infants who have SIDS. And in fact, when they did further analyses, what they found was that there was no increase in risk, right? So the amount of SIDS cases that happened in close proximity to vaccination was exactly what you would expect by chance alone. So descriptive epidemiology leading to a hypothesis. There are a number of examples. Toxic shock syndrome and tampon use. This is one that Art actually worked on in his career. AIDS and homosexual sex or drug use. And alfalfa and E. coli. Those are just 3 examples. You could probably think of a million other examples of where descriptive epidemiology has led to a hypothesis. Typically in outbreak investigations, that's what they do in the first place, is they go in, do a number of interviews to just get some basic data on some of the cases and start to formulate hypotheses about what might be the cause of the outbreak. Okay, so for tampon use and toxic shock syndrome, you guys all know this story, right? It's in the late 70s, early 80s, okay? They had this sudden spike of toxic shock syndrome, okay? It's basically a new syndrome that was being described. Of the first 55 cases, 52 of them were women, all right? And of the 40 women that they had data for with menstrual history, 38% of them had onset during menstruation. So that led them to believe that it probably had something to do with menstruation. So here's just one of the original reports on the MMWR. You guys know what the MMWR is? Morbidity and Mortality Weekly Report, right? It's a report put out by the CDC on a weekly basis. Okay. And so this report kind of goes first into saying, like, here we have this new syndrome. This is what it looks like. Okay, so here, toxic shock syndrome typically begins with suddenly high fever, vomiting, and profuse watery diarrhea, sometimes accompanied by sore throat, headache. So they describe the new syndrome, right? And then they tell a little bit about what the laboratory findings, the clinical laboratory findings look like in the patients. And then go on to talk about the cases and what they've noticed about the cases. And this is really about hypothesis generation. Okay, there were a lot of women. It's happening very close to or when they're menstruating. And so that led to a number of hypotheses, right? Could be tampons, the use of tampons, perhaps it's absorbency, the chemical composition, duration of use, etc. Douching, sexual practices, the type of underwear or pants that the woman was wearing, or perhaps swimming or bathing, contraceptive devices or OTC medications, right? And in the end, they proved it was tampon use. And what was it about the tampons? Anybody know? They were super absorbent, right? So in fact, they at first associated it with tampon use, and there were 2 different hypotheses that were generated. One said it had to do with the super absorbency and the fact that the women would leave the tampons in for a really long time. And the other hypothesis was that it was something about the chemicals in the tampons, right? And that those chemicals were what was actually causing the infections. So those are 2 very different hypotheses, right? So if those are your hypotheses, how would you test that? You could do that, but it would actually be a cohort study in that case, because cohorts you select on exposure. Case control studies you should never select on exposure. But I think what they did do with case control studies, right? So your cases are people who have toxic shock syndrome, and your controls were age and sex matched persons who did not have toxic shock syndrome. But what would you be measuring? What would be one of the exposures of interest? Okay, they all use tampons, maybe. Maybe you'd limit it to people who use tampons. Could be different types of tampons, right? So if you looked at women who use the same type of tampon, okay, And some of them had toxic shock syndrome, and some of them did not get toxic shock syndrome. What would you expect to see if the hypothesis that it had to do with the women leaving the tampon in for longer periods of time was correct? That it had to do with absorbency. I kind of gave away the answer, yes, right? You would expect to see women leaving the tampons in for longer periods of time would have an increased risk of toxic shock syndrome, okay? Or that would be associated with being a case, okay? Whereas if it was the chemical composition, if it was an exposure to chemicals, what would you expect to see? Yep, but if they were using the same type of tampon. Maybe, but what you might also expect to see is that actually if they change them more often, you would get more exposure to the chemical, right? So that would be, you'd expect to see actually exactly the opposite. Do you guys see that? So they did that study basically, and what they found was that certainly it did seem that leaving them in for longer increased your odds of having toxic shock syndrome. Okay, so HIV, right? When HIV came around, it was a new disease, AIDS.
Sorry, just about the last slide. All of these hypotheses are related to reproductive system. Was this were these hypotheses generated because they were all having menstruation?
Yeah. So they said, okay, it's during menstruation. It must be something to do with menstruation. There's some change in the reproductive system, and these women are all having some exposure. What is the exposure that they're having? And it has to be kind of a newer exposure, right? Because it was a new syndrome. It suddenly popped up. Okay, so for AIDS, right? The investigation of AIDS and figuring out that HIV causes AIDS started actually with a case report, a case series, also again published in the MMWR. So basically, some clinicians in Los Angeles noticed that they were getting a lot of infections of pneumocystis pneumonia, okay, in young men. This was out of the ordinary. And in fact, a quote from one of the clinicians was, "In this age and type of otherwise healthy patient, oral thrush is as rare as hen's teeth." So they said, okay, we've got all these cases of pneumonia, okay? They all also have oral thrush. This is something that we completely would not expect to see, and it actually led them to first hypothesize that there was some sort of immunodeficiency in these patients, okay? And luckily, some of the patients were at a teaching hospital that had a lot of assays that they could do on T cells, and so they were able to figure out quite quickly that, in fact, that their CD4 counts were very low. So then people went on. There were many more case series after that, right? Kaposi sarcoma and pneumocystis pneumonia. And this was in New York City and California. So they had a number of other case series, and they started to investigate what is it that these cases have in common. Okay. And all of the cases were in homosexual men, or all of the first cases were in homosexual men, right? And after talking to the cases, they realized that they had very high rates of recreational drug use. So it led to two different competing hypotheses. One was that it was sexual practice. So because the cases occurred in homosexual men, it had something to do with homosexual sex. There were a lot of different hypotheses surrounding that. But 90% of the first cases also had exposure to recreational drug use. And so there was also the hypothesis that these exposure to poppers was actually leading to death of T cells.
What are poppers?
It's something nitrate. It's basically these things that you inhale, and they give you a very sudden and short-lived high. And a lot of these men were doing that while they were having sex. I believe they're illegal, certainly. Yeah?
Yeah, they sell them on the cash.
Oh, that's right, as video head cleaner or something, right? Isn't that? Yeah.
It's not, they don't say that it's for inhalation, but yeah, you can buy it. It's like incense or
Yeah. Yeah, I think they actually still sell it under video head cleaner or liquid or something like that. So it's okay. What you did not expect to learn in epidemiology class today, right? Okay, so another example, all right, of a case series is alfalfa and E. coli. So that should be a large O there. So O157H7. Okay, in 1997, there were outbreaks of E. coli in Virginia and Michigan. Okay, prior outbreaks had been linked to ground beef. You guys all remember those, right? Don't go eat a Jack in the Box, I think it was, etc. But this was a little different. So when they went to go look at the cases, 70% of the cases were women. The median age was 31. You guys think these women are eating a lot of hamburgers? Is that the population you would expect to be the cases if hamburgers were the exposure that was causing the outbreak? No, right? That's exactly the population you would probably expect not to find. So they look at that population and they immediately start to think salads, right? Because what do 30-year-old women eat? They eat salads. Besides, there was a prior outbreak that had actually been related to lettuce. Okay, so they did interviews. They take like the first 7 cases. Okay, you go do interviews, just some descriptive epi. Think of as many different things as you possibly can to ask the cases about. The interviews really centered around salads. And what they identified in those interviews was that a lot of these cases had had exposure to alfalfa sprouts, right? They had put alfalfa sprouts on their salads or sandwiches in the last week. And they identified that as a possible cause and then went on to do a case control study, right, to confirm that that was indeed the probable exposure. All right, there are also laboratory or animal findings leading to an epidemiologic hypothesis. Okay, aluminum intake and Alzheimer's disease, folate deficiency, and neural tube defects. So basically the idea is you show this in an animal model, all right, and that leads you to hypothesize that that's what's happening in humans as well. There's also an analogy leading to epidemiologic hypotheses, so ethyl mercury and autism, right, that is an additive to some vaccines. And the thought was, well, methyl mercury is linked to neurocognitive damage in animals and humans, all right? So why wouldn't this then be potentially harmful and linked to autism? There's Alzheimer's disease and head trauma. So repeated head trauma, like in boxers, right, is linked to dementia, so punch drunk syndrome. Or cigarette smoking and cervical cancer, all right? Smoking is associated with squamous cell cancer at other body sites, so in the lung. So why wouldn't it potentially be linked to cervical cancer as well? So this is just where are we coming up with ideas that we can then test, right? Then there's common sense leading to an epidemiologic hypothesis, water/sanitation and diarrhea, okay? And luck, chance can also lead to an epidemiologic hypothesis. One example of that is electromagnetic fields and cancer. And here we have an article about, what was her name? Nancy Wertheimer. So she was an epidemiologist. She actually took some time off to have kids and take care of her kids, wanted to get back in the field, was very interested in leukemia. And so she started studying cases of childhood leukemia. And she noticed that children who had lived at their house for basically their entire young life and hadn't moved around a lot seemed to be more likely to have leukemia. And she was wondering if it was something about these houses, some sort of exposure that the kids were having. And so she started driving around and basically just visiting the house, the birth address of every child in the area that had developed leukemia between 1950 and 1969. And what she noticed were that there were those houses, just by chance, she kind of like was walking down an alley, basically around the back of the house. And she said it didn't really occur to her at that moment. But she noticed that those houses were very close to transformers, right? So that led to the hypothesis that exposure could lead to leukemia in early childhood. There's also unanticipated research findings leading, as a source of hypotheses, okay? So vitamin A and childhood mortality, maternal influenza vaccination and infant influenza infection, circumcision, and HIV. Okay, so these are all hypotheses that were generated actually with analytic studies. Okay, the study was designed to look at something else, and then people said, hey, wait a minute, I see an association in the data. Okay, so it was not the hypothesis that they were testing. So vitamin A and childhood mortality. There's a guy named Al Sommer. He's a professor. He's an ophthalmologist, okay? And so he was interested in studying the eye's vitamin A deficiency. Okay, I'm probably not going to say this correctly, but xerophthalmia, right? It's basically dry eyes. In severe forms, it can cause these lesions, which are very characteristic, and night blindness, okay? And so he was doing a study of vitamin A supplementation, okay, and the effect on the eyes. But what he noticed was that the children who developed this disease were actually much more likely to die. That was kind of surprising because this would not normally lead to death. And so he hypothesized that vitamin A deficiency might be a significant contributor to childhood mortality. Actually went on, that's basically been his entire career, looking at vitamin A deficiency. And anybody know what they found? No. Okay. Has anybody ever been to like Central America? Yes. Have you ever looked at a sugar package in Central America? Actually, it says fortified with vitamin A in a lot of the countries. I thought that was very funny the first time I saw it. Or if you ever are in a developing country during a big vaccine initiative where they move out and they try to vaccinate all the children, you'll see all the vaccines, and then there's always like, maybe the shape of a carrot, right? And it has the hundreds of thousands or doses that they're expecting to give. And so what they actually found with vitamin A was that it does reduce childhood mortality by up to 30%, all right? And specifically mortality due to some diseases, including measles.
They fortify sugar with beta-carotene, vitamin A and beta-carotene.
Yeah, I'm not sure what? Yeah, no, still. Like in Nicaragua, I actually have a picture, I should have put it in here. I have a picture that I'm holding up a sugar bag and it says fortified with vitamin A, just because I thought it was really funny and I had to send it to Al Sommer. What? It's fortified with vitamin A, exactly, right? So that's milk. You just figure out what is a common, that they would commonly give to children, and then you can fortify that item with vitamin A. In Nicaragua, it happens to be sugar because they all drink refrescos all the time, which are these sugary fruit drinks. Yeah, that's another example of fortifying something, but it isn't. I don't think they discovered that by accident from another study. So influenza vaccination and infant influenza infection. So there was an RTC that was done in a randomized control trial. You guys all familiar what a randomized control trial is? Yes, no? Raise your hand if you do not know what a randomized control trial is. Okay, so a randomized control trial, very briefly, which we will talk about in the class, is you take a group of people and you randomize them to an exposure. In this case, they were pregnant women, and they were being randomized to either get the pneumococcal immunization, which was the exposure of interest. They wanted to see what the effect of pneumococcal immunization would be on mothers and their infants for pneumonia, or you randomize them to be the control group. And often, for ethical reasons, you want to give the control group, the people in your study, a benefit, right? And so they will give them some other immunization. In this case, they gave them influenza. They were not expecting any kind of real results from influenza. They thought it would probably protect the women from getting influenza during pregnancy, okay? And pregnant women are at increased risk for severe outcomes if they get influenza. But what they found actually was that immunizing pregnant women with the influenza vaccine protected them more, their infants, more from pneumonia than giving the pneumococcal immunization to women. Okay, so their primary outcome of interest was pneumonia hospitalization in infants. All right, and what they also found was that actually if you vaccinate pregnant women, their infants up to age 6 months would have there was a proven efficacy of vaccinating. So you vaccinate the women, and the efficacy against influenza infection in infants up to 6 months of age was 63%. And that was an unexpected finding, okay, which led to the hypothesis that you could vaccinate pregnant women and thereby protect infants from getting influenza. Yeah, they did. I mean, it was a very nicely done RCT. It's just that they didn't find the association that they were expecting, so they did control for all of those kinds of things. So there's also other epidemiologists and published reports as a source of hypotheses. So basically, you can truly new hypotheses that are biologically plausible and feasible to test can be hard to find. All right. So it's kind of more common to retest or refine old hypotheses. All right. So we do a lot of studies of things that have basically already been studied in one form or another before. So an example of that is oral contraceptive pills and the risk of breast cancer. There are well over 100 published analytic studies. Okay. But at one point, the previous studies had really conflicting results. Some of them were poorly done. All right. They might have inadequate power to exclude a small but real effect. All right. The formulation of oral contraceptive pills has changed over time as well. You might want to look at specific subgroups or subhypotheses, and you would need a separate study of those. Or you might want more follow-up time, longer duration of exposure to see the long-term effects, right? So all of these things are. So some of the things that an epidemiologist might want to study once you figure out that, okay, it does appear that this exposure leads to disease, right? You then want to do subgroup analyses. So in the case of oral contraceptive pills and breast cancer, people are interested in, is it current or recent use that is important, or long-term use? The duration of use, okay? The interval since the first use. So maybe you don't have to use it the entire time. Maybe it just matters when you started and how long it's been since you started using OCPs. Early use in early life before the first pregnancy. Is that what is responsible for the increased risk of breast cancer? Use late in life, maybe, after age 40. The age at diagnosis. The tumor size or stage, is that related to OCP? Or how is that related to OCP use? Hormone receptor status, genetic susceptibility, all sorts of things. Okay. So that's basically how we generate hypotheses. So I'm going to very briefly touch on, and we will talk a lot more about this later on when we talk about testing hypotheses and statistical tests. But I didn't feel that I could talk about hypotheses without at least touching on the null hypothesis. Okay, so in epidemiology, we typically test the null hypothesis. All right? The reason for this is a lot of epidemiologic hypotheses are vague. You actually, when you do write a hypothesis, you want to make it as specific as possible. But a lot of times, when you start first looking at something like, does oral contraceptive use lead to breast cancer? You have this very vague hypothesis, right? Basically, oral contraceptive use leads to breast cancer. So the null hypothesis is the negation of the causal hypothesis, right? So the causal hypothesis is, in this case, right, oral contraceptive pill leads to breast cancer. Okay, the null is just the opposite of that. Oral contraceptive use does not lead to breast cancer. All right? And here we have smoking causes cardiovascular disease, right? That's the causal hypothesis. So the null hypothesis, which you'd actually be testing, is smoking does not cause cardiovascular disease. You guys all seen this in stats class? Yeah, okay, good. All right. So the null hypothesis states that there's no association. Basically, it's stating that if you were looking at a ratio, so if you're looking at like the odds ratio, the relative risk, okay, it's not different from 1, okay? So that's equally likely in the exposed and non-exposed. If you're looking at a difference measure, okay, then your difference measure would be 0. The alternative hypothesis is that there is an association between the exposure and disease. And then what you do is basically look at the compatibility of the null hypothesis and study data. And you do that using a statistical test beyond the scope of this lecture, but the type of test really is going to depend on the study design and also the type of measurement that you have. Okay? And the end result is that you're either going to reject the null hypothesis or not reject the null hypothesis. Okay, multiple hypothesis testing. So in epidemiology, especially at the very beginning of things, we may be testing multiple hypotheses. It's especially true in outbreak investigations where you're looking at a ton of different exposures. Okay, that can also be true in investigations of endemic diseases that are cryptic in origin. And then that's very true of data dredging. So the thing about multiple hypothesis testing is that it makes studies much more efficient. Okay, you're able to ask about multiple exposures or potentially outcomes, maybe if you have a cohort study, right, rather than a single association. But it raises questions about the statistical significance of your finding. So the question that it basically raises is this a true association or is it something just due to chance? If I asked enough questions, right, I'm likely to see an association with anything, basically, right? If I have cases of E. coli infection, and I think of 100 completely not related things, and I have 40 cases, there's probably something that could be statistically significant, even though there is no plausible way that it causes, that it was the cause of infection. For example, something like eye color. Do you guys, or am I making this more confusing? Yeah. So it's basically, if you look at enough things, something by chance is probably going to be associated.
Isn't that a potential problem with data dredging?
Oh, that's a huge problem with data dredging.
Scientific method, you're not supposed to skip over or hypothesize and dig through your data, find something, and then go back and make up hypothesis.
Yeah, so that is the problem with data dredging. And so, but you can use data dredging for hypothesis generation, right? If you find an association, it seems like it is biologically plausible. What you then need to do is go on and design a study to actually test your hypothesis. So any result that you get due to multiple hypothesis testing must be evaluated critically. And if you find something that's really unexpected, or even if you find something that's kind of unexpected, it should be repeated several times. Okay. So in epidemiology, we basically go and redo the same study or a variation of the same study over and over again in different populations to really make sure that the finding holds up. And that is it, and we've ended early. Are there any questions?